Right, team, welcome back to Neurospicy Nursing. We have another 5 slide fix today. This one is breaking down PDA, and let's get on into it. So, PDA is a persistent connection between the aorta and the pulmonary artery. Because aortic pressure is higher, the blood flow is going to go from left to right. That extra pulmonary blood flow is going to cause pulmonary congestion and volume overload of the left aorta and the left ventricle. And then over time, you're going to get that very classic left to right shunting symptoms like tachypnea, diaphoresis, especially when feeding, and poor weight gain. So the clinical features, clinically, PDA is going to give you kind of like a machine-like murmur, like I mentioned in the overarching video when talking about congenital heart defects. Um, Another thing to remember about it is that you'll have bounding pulses and then a widened pulse pressure. Small PDAs tend to be asymptomatic, and larger ones are going to show your stereotypical heart failure signs and symptoms. And that's because that pulmonary flow, that pulmonary blood flow is increased. And then these infants, because of that, are going to be at higher risk for respiratory infections. Treatment depends on the size and the symptoms. Indomethacin is used as a closure for infants who can obviously, have it, right? If they have like a renal issue, we're not going to give them indomethacin. But if it's appropriate, indomethacin is one. If they have a persistent PDA, we can do a catheter-based closure, which is standard. And if the anatomy isn't suitable for that, or any other medical therapy fails, we can do a surgical ligation. For post-closure, we're going to monitor for residual shunting, arrhythmias, bleeding, etc. Nursing care, it's all about, for the most part, monitoring the perfusion, their feeding tolerance, and their respiratory efforts. We really have to also make sure that we're assessing those pulses. Bounding upper extremity pulses are super classic in PDA. We're gonna auscultate for that machine-like murmur after it's been fixed. They shouldn't have it anymore. It should go away. Maybe not immediately, but it does go away. And then before they get the catheter, we're keeping them NPO. We're getting their baseline pulses. We're doing an allergy check. All your typical surgery types of things. Consents from parents, whatnot. After that, cath, keeping the leg straight, just like you would for any other catheter, right? Because we don't want to mess anything up, cause any bleeding, cause any hematomas. We're checking distal pulses because we have to monitor for perfusion. We're watching for any arrhythmias. And then if they're getting this done as an infant, we're going to monitor them for heart failure symptoms, obviously, but we're also going to cluster the care just so that we don't overstimulate them and tire them out. For our parents, we're reassuring them that it's a super common abnormality and it's very, very treatable and outcomes are excellent. Okay. We're teaching them to make sure that we're watching for increased workup breathing, the sweating when feeding, and then the poor weight gain. So FTT is another thing that they can get if they have a PDA. After they've had the closure, we still have to follow up with cardiology. Cardiology, even before that surgery, they can be like, oh, we need to do endocarditis prophylaxis. You're going to see that a lot with all of these um, conditions is the endocarditis prophylaxis. And then I do have a lecture on endocarditis itself. But after it, we're avoiding strenuous activity. We're watching for fever, chest pain, palpitations, all of that, just like in any other cardiac surgery. Okay, here are the resources. And that's all I have for you guys. Make sure you watch out for all of the other lectures on all of the different congenital heart defects. But yeah, thanks guys. Bye.